Hello, friends. So I'll be talking on this exam topic, obstructive shock. In this, I'll be specifically talking on cardiac tamponade. So this possibly was asked as a question in one of the exams. So I wish to acknowledge my colleague, Dr. Pradeep Surli, for helping me develop this content. So the main content on in this topic would be more on physiological ramifications in cardiac tamponade and what really happens to various issues in cardiac tamponade. So I'll just show you a couple of videos as to how the tamponade looks. So as you see, this is an echo, and you see this is the pericardial effusion. So, and this is the parasternal view. So you have a LA and LV, and you will see mainly the main tenets in cardiac tamponade is there is a diastolic collapse of the LA and LV that happens. And this is another video. You can just pay attention to what happens during the diastolic. So you see there is a collapse of the LV that happens, and there is a collapse of the atrium that happens. And that is the primordial sort of a hemodynamic effect that tends to happen. And that is the hallmark in tamponade. So I'll take you through certain schematic diagrams to get you to understand what really happens. So just let us look into the background. So with regards to epidemiology, so there is a mortality association with cardiac tamponade. And this was a study published in 2011 where they looked at around 10,000 patients. So the attributable mortality of 1 year was 11 to 26% in someone who has pericardial effusion. And this was a study that came in from France where they looked at the etiological aspects of cardiac tamponade. They looked at 106 patients with large pericardial effusion, where there is a diastolic collapse of 20 millimeters, and they saw that cancer was the leading cause of cardiac tamponade, 36%, followed by idiopathic, which was 30%, infection was 21%, myxedema was 8%, and autoimmune. So this, as you see, this study is a little oldish study, 2008, but usually in the most literature referenced in the cardiology, the commonest cause of cardiac tamponade is usually interventional post-intervention, post-coronary angiogram or angioplasty intervention. The cause of cardiac tamponade seems to be more commoner in the cardiac literature, but this is the study from France where cancer is put as a top cause. So if you look, this is from the cardiology text. Cardiac intervention leads to cardiac tamponade in up to one third. Cancer is up to one fourth. Infection and inflammatory is about one fifth, and mechanical complication of myocardial infarction is 10%, dissection is less than 10%. So this is possibly what I think as intensivists we could keep in mind. Even in our practice, we see cardiac tamponade mostly being addressed in CCU and where things may have happened following certain interventions. And this is what I have also seen in our hospital. Cancer patients do come to our ICU, and them causing cardiac tamponade, we have seen in a much lesser proportion. So just pictorially, what is of interest in ICU is acute tamponade. So as I already elucidated, the commonest cause is post-cardiac intervention and cancer. Cardiac rupture also is one of the common. And myocardial infarction and post-intervention, that is something what we tend to see often in our clinical practice. Aortic dissection, type A aortic dissection is also one of the commoner cause. And in one of the study, the percentage is put as 24.7%. They looked at 308 patients with cardiac tamponade. 24.7% was due to type A dissection of the aorta, and any malignancies, tumor, or any interventions, inflammatory and infection. So these are just a pictorial representation of common cause. But for all our intensive care friends, the easiest way to remember is the cardiac interventions, post-MI cardiac interventions leading to tamponade as a complication is the commoner one, followed by cancer, and then followed by other causes like infection, inflammatory, and dissection. So now we'll slowly move to the pathophysiology. So this is more of physiological effects of cardiac tamponade. So basically, you see the pericardial pressure, like pleural pressure, is a negative. In a spontaneously breathing, it is a negative. So during inspiration, the pericardial pressure comes down, and during expiration, it increases. And there is always a delta pressure, which means there is always transmural pressure. There is always a pressure difference between the right atrial pressure and the pericardial pressure. There's always a pressure difference, which we call as a transmural pressure. So in cardiac tamponade, this transmural pressure becomes negligible. So transmural pressure is the difference between right atrial pressure and the pericardial pressure. Usually there needs to be some difference between the right atrial pressure and the pericardial pressure. But if you see in cardiac tamponade, so these both the pressure difference between right. So there is equalization of the pressure between the atrium and the pericardium. So there is this is the hallmark of cardiac tamponade. There is no pressure difference between the right atrium and the pericardium, which is meant to be present in normal situation. In cardiac tamponade, there is equalization of pressure, and this delta pressure becomes negligible. And in the CVP trace, this is commonly asked in exam. These traces are shown in exam and asked. So what happens to the CVP trace because there is a plethoric IVC that happens in cardiac tamponade. So there will be a very deep X descent, and this is a very hallmark of cardiac tamponade, and the wide descent becomes uh, so it becomes less, or there is a insignificant wide descent, and the X descent becomes very pronounced. And so this is a typical feature of cardiac tamponade, and X descent is due to the right atrial filling from the SVC, and that gets prolonged. So there is a deep X descent, and the wide descent gets mitigated. So this is the hallmark feature of cardiac tamponade. So just I'll show you pictorially as to what really happens during inspiration and expiration in cardiac tamponade. This is very important so the whole crux of cardiac tamponade depends on the changes that happens in the heart during inspiration and during expiration. So if you look at heart as a four chamber, so in cardiac tamponade, so this is a pericardial sac and there is a fluid accumulation here. There is increase in the pericardial pressure. So it is very intuitive. There is a fluid accumulation in the pericardial sac. There is increase in the pericardial pressure. And this increase in the pericardial pressure, as I said, leads to equalization of the pressure between the both atria and both the ventricles. There is equalization of the pressure that happens. And during inspiration, normally, as you know, there is increase in the RA filling and the RV filling because there is increase in the RV filling. So RV cannot accommodate increased blood that flows into the RA and RV. Because of this, the septum, the interventricular septum bulges to the left. So this is the typical changes physiologically that happens. Because the RV cannot accommodate increased filling during inspiration, the interventricular septum bulges to the left. That's what we call as a deep septum, or it bulges to the left. Because it bulges into the left ventricle, the left ventricular volume comes down. Because obviously there's a bulge of the interventricular septum, the LV cannot accommodate more volume. There is reduced in the left ventricular volume, which leads to reduced in the left ventricular stroke volume, which leads to reduction in the systolic pressure. And this changes is what we see as pulsus paradoxus in cardiac tamponade. So very simple to remember. During inspiration, obviously there is in spontaneous breathing, there is increase in the RA filling, RV filling. RV cannot accommodate that increased filling. So the pressure increases, pushes the interventricular septum to the left. Because it pushes and compromises the space in the LV volume comes down. There is reduction in the stroke volume, reduction in the systolic pressure. And the opposite happens in the right ventricular. There is increase in the stroke volume because of the increased filling during inspiration. And this leads to increase in the transmural pressure, which I said, which is equal to intracardiac pressure and intrathoracic pressure. And this leads to increased wall stress and increase in the left ventricular afterload. So these are the changes that happen during inspiration. The exact opposite happens during expiration. So expiration, there is reduced filling of the RV. So during expiration, as you see, there is obviously equalization of pressure. There is reduced filling. During inspiration, there is increased filling in the RV. During expiration, there is reduced filling of the RV, and that leads to reduced stroke volume on the right side. In the left side, because there is movement of the septum back into the RV, there is increase in the left ventricular volume, increase in the left ventricular stroke volume, and there is increase in the systolic pressure. So this changes during inspiration and expiration, where during inspiration, there is increase in the RV, and decrease in the LV stroke volume. During expiration, there is increase in the RV stroke volume. During expiration, there is reduction in the RV stroke volume and increase in the LV stroke volume. This leads to pulsus paradoxus, which you typically see as a hallmark in cardiac tamponade. So this physiologically you need to understand. So during inspiration, there is increase in the stroke volume and reduction in the left ventricular stroke volume. During expiration, the opposite happens. So in exams, if this question is asked, very simplistically, you can put this picture. So during inspiration, there is increase in the RV stroke volume and there is reduction in the LV stroke volume. And opposite happens during expiration, where there is reduction in the RV stroke volume and increase in the LV stroke volume. And these changes lead to the pulsus paradox. So if you just put this figure, then one would sort of reconcile that you have conceptually understood. So during inspiration, there is movement of the septum to the left, and your LV cavity comes down. There is LV volume reduces, stroke volume reduces, and there will be fall in the systolic pressure. During expiration, the opposite happens. The RV size comes down, the LV size increases, and LV stroke volume increases. There's increase in the systolic pressure. So if you just put this picture, then at least you will be very clear what happens during inspiration and expiration. So this we call it as ventricular interdependence. So the same thing in echocardiogram, we can assess how significantly these are affected by putting pulse Doppler. So the Doppler, what happens is the same thing. During inspiration, the RV volume increases. So your mitral, the tricuspid inflow, as you see, if you put a pulse Doppler here, tricuspid inflow is much better, is increased during inspiration. And the mitral inflow is significantly reduced because the LV volume is less and because of the bulging and the stroke volume is less and systolic pressure is less. So when you put a pulse Doppler, tricuspid inflow is more during inspiration and the mitral inflow is reduced during inspiration. And in expiration, the opposite happens. The tricuspid inflow reduces and the mitral inflow increases during expiration. And this we calculate how much reduction of mitral inflow happens during expiration. During inspiration is what we look at. So the mitral inflow, which is E wave, which is very simply you take an apical four-chamber view, put the pulse wave Doppler at the mitral valve, look at the E by A, which we all intensivists are used to. Look during inspiration and you compare with the expiration. If there is reduction of mitral inflow of more than 25%, that is significant, and that means there is a cardiac tamponade setting in. So it's a very simplistically, you can put a pulse wave Doppler in the mitral inflow and look at the change in inspiration and expiration. And this is how it looks. So during inspiration, it is come down and during expiration, it increases. And this change, if it is more than 25% in pulse wave, the mitral inflow during inspiration and during expiration, if there is a difference of more than 25%, then it is a significant sort of a hemodynamic instability or cardiac tamponade. So this is the Doppler indication of increase in ventricular interdependence. And same thing during expiration that we spoke about inspiration. During expiration, as you see, the mitral inflow increases. So we look at the tricuspid inflow during inspiration and we look at the decrease in the tricuspid inflow of more than 40% as a representation of significance. So mitral inflow difference of more than 25% and tricuspid inflow difference between inspiration and expiration of more than 40% is taken as significant. So as you see, during expiration, your tricuspid inflow is come down, mitral inflow is increased. So you look at mitral inflow difference during inspiration and tricuspid inflow difference during expiration. Very simple. So tricuspid inflow, you put a cursor in the tricuspid valve, put the pulse wave Doppler, and you will see the tricuspid inflow and difference between inspiration and expiration. You can see and trace it. If it's more than 40%, is taken as significant. So that is the Doppler assessment. And what happens to the pericardial pressure in acute? So there is a difference in acute and chronic tamponade. So just carefully look at this red wave. In acute tamponade, it is like intracranial pressure, where we say at certain threshold, a small change in the pressure, small changes in the volume significantly increases the pressure. So is the case in cardiac tamponade. You see in the red in acute tamponade, if you even remove 100 ml, there is a significant drop in the pericardial pressure. In chronic, if you see, because of ability of pericardium to bear with the increased volume, you need possibly up to 600 ml removal for the pressures to significantly come down. So this is very intuitive that in acute rise, small removal of the volume significantly reduces the pressure. in chronic pericardial effusion, you have a better ability to accommodate larger amount of fluid. So larger amount of fluid has to be removed to reduce the pericardial pressure. So that's all it means. And it's very similar to your ICP, where a small change in the volume leads to significant reduction in the pressure. So that's about the physiological changes. So the clinical features, typically the clinical features of cardiac tamponade is described by as Beck's triad. So where you have a distended jugular venous pulse, there is a muffled heart sounds, and there is hypotension. So they have categorized it into three grades: grade 1, grade 2, grade 3. Grade 1 is where your pericardial volume is less than 200 ml, cardiac index is normal, and the CVP map is also normal. CVP may be increased and heart rate will be increased, and Beck's triad is not present. So grade 2 is pericardial volume is more than 200 ml. Your cardiac index will start coming down. MAP will be normal or it can start reducing. CVP will be high in all the grades of cardiac tamponade and there will be tachycardia. Beck's triad plus or minus may be present. So grade 3 is more than 200 ml pericardial fluid, where you'll see drop in the cardiac output. MAP comes down significantly, CVP increases more significantly, and they can have bradycardia and impending sort of a cardiac arrest. So grade 3 is something that we really have to avoid, and possibly all interventions should happen somewhere in the grade 2, where the CVP is increased and you have a hypotension setting in. So these are some of the clinical features. So again, just to show some of the echo images, as you see during inspiration, the RV size is increased because there is increase in the RV volume and there is pushing of your interventricular septum. And and this is during expiration, your RV volume comes down and the LV volume increases. So again, this is the images to show diastolic collapse of the right atrium. Here you see pericardial effusion calling diastolic collapse of the right atrium, and here you see the diastolic collapse of the right ventricle. So just to summarize, so in exams, if obviously they have asked this question as a cardiac tamponade, it's good to put pictorially uh, to put your facts or to put your understanding so that it becomes evident to a examiner that you have a good conceptual understanding. So if you just put this figure, what really happens in cardiac temper? This is four-axis view, apical view, four-chamber view. So what you will see is basically you'll have a plethoric IVC. So IVC will be dilated, will be distended, and there'll be non-collapsibility of the IVC. And then there will be a diastolic collapse of the right atrium, and then there'll be a diastolic collapse of the ventricle. And then you'll have during inspiration, so there will be movement of the septum, which will become D-shaped or into the LV. And during expiration, there'll be movement back out to the septum into the RV. So if you write this, pretty much this is what happens in cardiac tamponade. There'll be a diastolic collapse of the RA, diastolic collapse of the RV, and during inspiration, the RV will be restricted in filling. There'll be increased filling in the RV, and interventricular septum will push to the LV, and it becomes D-shaped. And during expiration, the septum moves back into the RV. If you conceptually write this, you have pretty much understood what really happens in cardiac tamponade. And they have looked at the sensitivity and specificity. If you are having diastolic collapse of the right atrium, then the fact that someone is having cardiac tamponade sensitivity is very good, 95 to 100%, and specificity is 70 to 80%. And if there is a diastolic collapse of the right ventricle, both sensitivity and specificity is much higher. As you see, it's 90 to 95%, specificity becomes 95 to 100%. If there is IVC is plethoric, non-collapsibility, sensitivity is very high, but specificity is less, which means there are a lot of other reasons why IVC can be plethoric. So that's why specificity comes down. So these are some of the sensitivities and specificities. So the key hallmark is the diastolic collapse of the RA, and RV has a higher sensitivity and specificity. And if it is corroborated with plethoric IVC, it adds on to the diagnosis of cardiac tamponade. So hopefully this figure makes it little simplistic for you to understand. And and to go few steps forward, even the Doppler sort of a changes that happen is pretty much commensurate to these physiological changes that you see. So as you see, these are images to show this is the diastolic collapse of the right ventricle, and this is the diastolic collapse of the right atrium. So as you see, it is quite intuitive to see what happens. There will be a collapse of the RA and RV and this diastolic collapse of the RV is happening at the early diastole, which is the beginning of the T wave here. Okay, now we'll move to the volume. So the most of the cardiac tamponade, when a question is asked, it is to talk about the physiological changes and the clinical features, which are, you know, which is something which one needs to have a good clarity on. So treatment, the whole concept is whether there is a room for volume resuscitation on fluid bolus. So this was a study from the Spain where they looked at, because this is controversial whether they have any room for fluid. Because if in ICU, if you have an IVC which is plethoric, then we know for sure that we cannot give any more fluid. And but here this is a study where they looked at 500 patients where they are given fluid bolus versus no fluid bolus. As you see, the map tends to increase when you give a small fluid bolus, and pericardial pressure increases, right atrial pressure increases, left ventricular, and they found increase in the cardiac index of more than 10% happened in 48% of the patients where fluid bolus was given. So the conclusions the authors made was, if patient is hypovolemic, if your test for fluid responsiveness shows that he's hypovolemic, fluid bolus may be beneficial. But if someone is euvolemic or in a fluid overload, obviously you wouldn't give fluid bolus. So the take home is possibly we have to look at mini fluid boluses in this situation and adopt the science of fluid responsiveness. And when there is fluid responsiveness, obviously you cannot give a big fluid bolus of 100. Maybe you have to stick to giving small fluid boluses like 100 ml or 200 ml and see the response and take it from there. So catecholamines, so the studies have shown dobutamine at 10 micrograms per kg per minute has shown to increase the heart rate, stroke volume, cardiac output, and oxygen consumption. And this was found to be superior to noradrenaline, especially in cardiac tamponade. But having said that, since they'll have tachycardia in grade 1 and grade 2, they'll have severe tachycardia. So vasopressors is preferred. So noradrenaline may be preferred to improve the MAP and perfusion pressure, because we do not want more tachycardia. They'll already be tachycardic. Even if you use dobutamine to increase cardiac output, the dose should be limited to less than 10 micrograms or up to 10 micrograms, not more than that. So the definitive treatment for cardiac tamponade will be pericardiocentesis, and this is obviously done by cardiologists who are privileged to doing this procedure. And nowadays, it is almost a norm that this pericardiocentesis has to be done under ultrasound guidance. I'll show you one nice sort of a video. You can Google. There is a nice video in any JM, which I have taken. I have edited that video and put it here. So it is fairly simple procedure to do it under ultrasound guidance. So pericardiotomy, where a surgical intervention is done in only specific situation where pericardiocentesis may not be possible for whatever reason, technical reasons, or if you have loculated or compartment, like loculated pleural effusion or compartmentalized pericardial effusion, pericardiotomy, which is a surgical procedure, may have to be done, or when there is hematoma, because as I said, the commoner cause of cardiac tamponade is post angio intervention. So many a times it may be hematoma, and that may be organized, and that cannot come when there is when pericardiocentesis is attempted. So in these situations, you may have to do pericardiotomy, or where there is an infective cause or inflammatory cause where the diagnosis has to be established, where we need a pericardial biopsy. So at that point of time, the patients have to be subjected to pericardiotomy to get a biopsy yield of the specimen. So that's about the whole cardiac tamponade science. So if you remember that picture, what happens during inspiration, your basically RV is getting full and there is increase in the RV stroke volume, and your LV stroke volume comes down because of reduction in the LV volume, and your interventricular septum is pushed to the left. So that interventricular dependence, if you remember, I think that should be good enough in conceptually understanding the whole. And that is the point. The difference in inspiration and expiration is what leads to pulsus paradoxus and the Beck's triad. And the pulse wave Doppler, where you show during inspiration, there is a difference of 25% in the mitral inflow, and during expiration, there is a difference of 40%, 45% in the tricuspid inflow. If that you understand, that pretty much summarizes the whole concept of cardiac tamponade. So I'll end this video with a video of pericardiocentesis that's come in NEJM. So I acknowledge NEJM. So this video is taken from NEJM. You can just go through this. So basically, they're looking at a subxiphoid approach to do a pericardiocentesis. They're giving local here. So this cardiac tamponade procedure is being shown in a patient who's had a cardiac arrest due to cardiac tamponade. So the key way to do this is to do ultrasound guided pericardiocentesis. In this day and age, I think most ICUs have ultrasound, so it is good to do. If ultrasound is not available, they connect to the ECG probe and then do it in a blind way. But in this day and age, I would expect that every ICU has an echo and it will be done under ultrasound guidance. The blind approach is shown to have higher morbidity and mortality. It's very easy to look into subcostal view and look at the pericardial effusion. This is a nice image. Just have a look. It's entering into the pericardium. So this is a nice 3D view. It entered. So this has penetrated the pericardium. So you can see the needle coming there into the pericardial sac. There is a sternum approach and there is a parasternal approach. So this is a parasternal approach they're showing. See, if the ultrasound is not available, they're connecting an ECG lead. And then you have to look at the ECG. There'll be ST elevation if it touches the myocardium. So this is to exercise caution that you are in the safe situation to aspirate the fluid. So where you are aspirating needle is connected to the ECG probe and looking at the ST elevation. This is a blind approach, which pretty much I believe is obsolete now. None of us can think of doing blind approach because the risk of complication and cardiac rupture is more with blind approach. Okay, so I'll end this video. So after you've done the procedure, obviously you'll have to get an X-ray to see if there is a pneumothorax or any pleural effusion and so on and so forth that may have. That is the standard after any procedure. So the complications. So these are the complications which is expected. Okay, so I'll end that. So thank you one and all. So you can rehear to this lecture by visiting my website. I request if any of you have an interesting procedure or any good article, submit your manuscripts to the Journal of Acute Care. So this is a quarterly journal. So if there is any queries, please write to me. I will be more than happy. There is a separate section on video CME where we upload some interesting videos or images, or if you have any sort of a cardiac tamponade where you have done a procedure and you want it to be published in an interesting case, you can send this video CMEs, which is very unique to this journal. You can visit my website, www.drpradeeprangappa.com to read to this page. So thank you one and all.